I'm Charlotte Moser, co-director of the Vaccine Education Center at Children's Hospital of Philadelphia. And today on VEC Vaccine Notes, we're going to be talking about respiratory syncytial virus, or RSV. We'll talk about the disease, the different tools we have available to prevent RSV and in whom, and we'll also talk about some common questions we receive here at the Vaccine Education Center. And we'll finish up with a look at the relative risks and benefits. So let's get to it. Each year in the U.S., RSV kills about 10,000 people. About 100 to 300 of those are young children. But most often these deaths, like for influenza or COVID-19, other common fall respiratory viruses, people don't hear about these deaths. They don't make headlines. So a lot of people don't even realize they're happening. In fact, RSV can be particularly dangerous for children in the first 6 months of life. So what is RSV? RSV is a virus in the family known as paramyxoviruses. Other viruses in this family include measles and mumps, but RSV would be considered probably more of a cousin than a sibling to those viruses. RSV was first isolated in the 1950s. It infects the cells that line our respiratory tract. So that means our nose, voice box, windpipe, and our breathing tubes and our lungs. When the virus infects these areas, it disrupts that cellular lining, and it also causes inflammation and excess mucus production. So symptoms kind of depend on where the virus is replicating. People might have a stuffy or a runny nose. They might have coughing or wheezing, and if it's replicating in their lungs, they may have trouble breathing. Young infants can often have bouts of apnea, which is short stoppages of breathing. People can also develop a fever, have a lack of energy or a lack of appetite, and children can get ear infections. RSV is transmitted through respiratory secretions, so most often from coughing and sneezing of infected individuals. But people can also get it through contaminated objects if a person coughs or sneezes on an object and then someone else comes along, touches that object, and then touches their eyes, nose, or mouth. Symptoms usually begin 3 to 5 days after exposure and last about 1 to 2 weeks. Anybody can get RSV, and people often have multiple bouts throughout the course of their lifetime. And for most people, they're going to have mild cold-like symptoms. But there are 3 groups in particular who are more likely to have severe RSV. This includes the elderly, the youngest infants, and then adults who have chronic conditions of the heart or lungs or immune-compromising conditions. Now, there are a few things to consider when we talk about RSV disease. Infants between 6 weeks and 6 months of age are the most likely to be hospitalized from this disease. Second, by the time children are 2 years of age, most have had at least one RSV infection. And when we look at children that are younger than 5 years of age, what we see every year is that about 2 million outpatient visits or visits to the doctor occur because of RSV, and 60 to 80,000 children are hospitalized each year because of RSV. Third, when we look at adults, we see that about 60,000 to 160,000 adults are hospitalized each year from RSV. So if you consider RSV, influenza, and COVID-19 together, these are fall and winter respiratory viruses that circulate around the same time and together cause millions of patient visits to their doctor's offices, tens to hundreds of thousands of hospitalizations, and tens of thousands of deaths. Now, of these 3 viruses, RSV causes the least number of deaths each year, but that's still 10,000 people who die from this single virus. So our ability to prevent it is important. So let's talk about prevention. Well, we used to have a product that was available to help the babies that were at highest risk of RSV, known as polovizumab, or the more easily pronounced brand name, Synagis. That product had some limitations with our ability to protect the general population. We'll talk more about that older product later during the common questions section, but for now, let's focus on these newer products that became available in 2023. They focus on protecting the most vulnerable populations, so elderly and high-risk adults, as well as the youngest infants. Now, the products available for the elderly and for high-risk adults are traditional vaccines. We give the vaccine, the person's body makes an immune response, and that immune response protects them if they come into contact with the virus later. That's known as active immunization because their own immune system creates the protective response. Now, when we talk about protecting younger babies, we use a different mechanism, something known as passive immunization. Passive immunization means that the protection is afforded by antibodies from an external source. And there are two different ways that we do this with babies. First, mothers can get the vaccine during pregnancy, and then her immune system will generate immunity, and some of the antibodies that her immune system generates will be passed to the baby through the placenta. The second option is known as monoclonal antibodies. And in this case, the baby gets a dose of monoclonal antibodies that will protect them during their first RSV season. Now, there are some specifics around the timing of both the maternal vaccination and the receipt of the monoclonal antibody products, and we'll get into that a little bit later. But for now, the important point here is that babies are protected by a mechanism known as passive immunization. And it's a short-lived protection, but it gets them through that first season with RSV where they're at the greatest risk for severe disease. And then eventually they're exposed to the virus and they make their own immune response. So let's talk about who should get each of these tools. First, let's focus on adults. So adults that are recommended to get the vaccine include those over 75 years of age and those between 50 and 74 years of age that have conditions that increase their risk. This includes people with chronic conditions of the heart, lungs, or kidneys, people with advanced kidney disease or diabetes that has caused organ damage, people with immune-compromising conditions, neuromuscular conditions, or neurologic conditions, anyone who would be considered to be at severe risk if they got a respiratory infection, as well as people who live in nursing homes and long-term care facilities, and those who are considered to be medically frail. Now, in all of these cases, people are recommended to get a single dose. It's not like the flu vaccine where you get this vaccine each year. Right now, people are recommended to get only a single dose. And we are continuing to monitor how long those protective immune responses last. So it is possible that in the future, people would be recommended to get additional doses. But for now, it's a single dose. Now, as we discussed, there are two different ways to protect babies. First, it's important to know that RSV is a seasonal virus that usually occurs throughout the United States between October and March. There are a few areas, such as Florida, Alaska, and areas outside of the continental United States where that season varies a bit. So if you're in one of those areas, talk to your healthcare provider about what the seasonality looks like where you're living. Now, if a family decides that they're going to protect the baby by maternal vaccination during pregnancy, there are a couple things to know. The woman would have to get the vaccine between 32 and 36 weeks of gestation, and that period of pregnancy would need to occur right before or during RSV season. So typically, maternal vaccination can occur between September and January. If a woman if that timing doesn't work, or if the woman has already had an RSV vaccine, then the baby would need to most likely be protected using the second choice, which are the monoclonal antibodies. Now, even if the timing works and the woman hasn't had a previous RSV vaccine, the family may still choose to use monoclonal antibodies as the way to protect the baby. So let's talk a little bit about that. There are two products. One is called nirsevimab. The brand name is Beyfortus. And the second is called clesrovimab with a brand name of Enflonsia. Each of these would be given to the baby if the baby is born during RSV season, a single dose, within the first week after birth, and preferably before they leave the hospital, or if they're born outside of RSV season. So for most babies, if they're born, say, between March and September, then they would get it as right at the start of RSV season, as long as they haven't yet reached 8 months of age. There are two other things to know regarding that protection of babies with these monoclonal antibodies. The first is that if a woman does get vaccinated prior to delivery and during that time window of 32 to 36 weeks, most often the baby will not also need monoclonal antibody. However, there are a few cases when the baby would still be recommended to get that based on either the timing, if the woman delivers before 2 weeks after getting that vaccine, or based on the maternal health or the baby's health. The second thing to know is that some babies are recommended to get a dose during their second RSV season. Between 8 and 19 months of age, some babies would be recommended to get a dose, and that would be based on their own health conditions. We have details about both of these scenarios on our RSV webpage at vaccine.chop.edu. So if you have questions about either of those situations, we recommend going to the webpage or talking to your child's healthcare provider, as they'll be able to sort through those details with you as well. So let's talk about how each of these products are made. When it comes to protecting adults, there are 3 vaccine options. 2, known as RSV and Abrysvo, are made using a single protein from the surface of the RSV virus. It's called protein F. The vaccines are both made using recombinant technology, which means that protein F, the gene for protein F, is put into cells that are grown in the lab, and as the cells reproduce, they make the protein, which is then purified to use as the vaccine. Now, there are 2 differences between RSV and Abrysvo that are worth noting. So far, they have not shown any differences when it comes to safety or effectiveness of these vaccines, but that will continue to be monitored, and it's still worth knowing about these differences. First, RSV has one protein F gene, whereas Abrysvo uses the protein F gene from 2 types of RSV, A and B. The total amount of protein F in the vaccine is the same. So again, it's not anticipated that this difference would cause any differences in terms of how well the vaccines work. The second difference between them is whether or not they use an adjuvant. So Abrysvo does not have an adjuvant, whereas RSV does. The adjuvant that's used in RSV is the same one that's used in the shingles vaccine. It's a combination of monophosphoryl A and QS21. Of note, only Abrysvo is approved for use in pregnancy at this time. Now, the third vaccine, called mRESVIA, is an mRNA version of vaccine. And that vaccine is made similar to the COVID-19 mRNA vaccines, where the mRNA for that same protein as the other 2 vaccines protect against, protein F, is delivered to the cells so that our own cells make protein F, and then our immune system realizes that it's foreign and responds to make an immune response against it. If you're not sure how mRNA vaccines work, we do have a link to an animation that shows how COVID-19 mRNA vaccines work on the RSV page of our website, vaccine.chop.edu. And the important thing to know is that the RSV mRNA vaccine would be working in a similar manner. Now, we know that to have protection against RSV, we need protection against that protein F that's on the surface of the virus. So when we make the monoclonal antibodies that protect babies, we actually make an antibody against protein F. And the antibody is produced similarly to how the recombinant vaccines are made, meaning that the gene for that antibody is put into cells that reproduce in the lab, and as the cells reproduce, they make the antibody, which is then purified to be given to the babies. So what do we know about how these products work? Most severe cases of RSV are those where the infection occurs in the lower respiratory tract. So that's what we measure to see how well these vaccines are working in adults. When we looked at the protein-based vaccines, they prevented about 70 to 90 out of every 100 lower respiratory tract infections. And when we looked at the mRNA version of the vaccine, it prevented about 60 to 80 of every 100 lower respiratory tract infections. Now remember, in infants, we're using passive immunization, meaning antibodies that came from another source. So to figure out how well those products are working, we looked at how well medical care visits or hospitalizations were decreased. So when a mom got the vaccine during pregnancy, 5 to 6 out of every 10 babies were protected against hospitalization from RSV. And when we looked at the monoclonal antibody products, nirsevimab and clesrovimab, we found that about 7 or 8 of every 10 babies were protected against needing medical care, specifically meaning not being hospitalized, not going to the emergency room, not ending up in the ICU, or not needing to have oxygen to breathe. Let's talk a little bit about the side effects now. For the vaccines, when adults get vaccinated, they get the typical side effects of pain and soreness and redness at the injection site. And some will have things like headache, nausea and diarrhea, fever, tiredness, or muscle and joint pain for a few days after receiving the vaccine. 2 concerns about severe side effects are worth noting. Both were realized during the clinical trials, and both continue to be monitored for safety even now. The first is that some elderly people seemed to develop Guillain-Barré syndrome, or GBS. GBS is a condition in which the immune system attacks a person's nervous system, and it can result in a paralysis that begins in the legs and moves upward, and sometimes can involve the muscles used for breathing. Now, during the clinical trials, small numbers of vaccinated people were developing GBS compared to the controls. Those numbers were higher. So after the vaccines became available and we continued monitoring for this condition, it was determined that it appears that GBS can be causally associated with vaccination against RSV. Only using the protein-based vaccines, the same has not been seen using the mRNA vaccines, but that continues to be monitored as well. The rate that they found was about up to 10 people out of every 1 million doses of vaccine that were given may develop GBS. So that's worth knowing. The second related to when the vaccine was given to pregnant people. And they found that in the vaccinated group, more people were having premature or early delivery compared with people in the control group who had not been vaccinated. So again, they studied this after the vaccine became available, and they found that those rates did not appear to actually be increased. Now, when the vaccine was approved for use, because there was a concern this may be an issue, the timing of 32 to 36 weeks was chosen specifically so that if there was an issue with preterm labor, it would happen closer to the time when a woman is at full term, so the baby would not have health effects as a result. But the good news is that subsequent testing did not appear to show this to be an issue. So it's now August 2025, and when we look at these 2 side effects that both were questions when it came to the clinical trials, we see that one, Guillain-Barré syndrome, was something that actually did seem to be occurring following vaccination. Again, rarely, up to 10 out of 1 million doses, but still a real effect. Whereas preterm labor did not seem to be a real effect. Again, we're continuing monitoring both of those. Now, when we look at the monoclonal antibodies in babies, those are well tolerated. Some babies will have pain or redness at the injection site, and a few will get a rash. Maybe about 1 of every 100 will develop a mild rash after they receive the product. But otherwise, there are no other concerns related to babies receiving these products. Let's talk about some common questions we receive here at the Vaccine Education Center. There are additional questions on the webpage that I'm not going to go through because we talked about them earlier in this session. But if you want to look at the complete list, please do go to the RSV webpage at vaccine.chop.edu so you can go through those at your leisure. Some people want to know, is the monoclonal antibody that babies get a vaccine? The short answer to this is no. Remember that babies are given these antibodies that were produced outside of their body. That's called passive immunization. And while these monoclonal antibodies that we use to protect babies against RSV are long-lasting, so they last about 5 months, so at the course of the baby's first RSV season, The reality is that antibodies given to someone from another source are not long-lived. To be protected, we need our own immune response that was developed by our immune system. That's active immunization, and vaccines provide that kind of immunization and protection. So therefore, the monoclonal antibodies are a type of protective immunization, but they are not vaccines. Some people wonder about the previous product that was available known as polivizumab or Synagis. That product became available in 1998, but it had two limitations, which was why only the highest risk infants were protected against RSV until we had these new products in 2023. The limitations on that previous antibody were that first, it wasn't long lasting. That meant that babies who were getting that type of protection had to get a shot every month throughout RSV season during their first year of life. So about 5 or 6 shots they would normally have to get depending on when they were born and when RSV season occurred. That leads to the second limitation, which was the cost. Because infants needed multiple doses, this product was very expensive to protect one person. So for those two reasons, we couldn't really protect all infants in an easy way until these new long-lasting products became available in 2023. Some people wonder if babies can get the RSV monoclonal antibody products at the same time as their vaccines. The answer to this question is yes. The vaccines will not affect the ability of the monoclonal antibodies to protect against RSV, and vice versa. The presence of those monoclonal antibodies that are specific for RSV will not interfere with the immune responses babies develop to their vaccines. Okay, so let's wrap up with a quick look at the relative risks and benefits of these products when it comes to protecting against RSV. Today we talked about the fact that virtually everybody will have RSV infections throughout their lives, more than once, and that for many people, those infections will be mild cold-like symptoms. But that there are each year millions of people who seek out medical care, tens to hundreds of thousands who end up in the hospital, and in the case of RSV, 10,000 people who will die from their infections. We know that there are specific groups that are at higher risk for having those severe infections, including the youngest of infants and the elderly, as well as adults who have conditions that increase their risk when they get respiratory infections, such as RSV. We know that during infections, RSV damages cells in the lining of our respiratory tract, and that leads to inflammation and excess mucus production, and that depending on where that happens, that can be problematic, particularly if it's occurring in the lower respiratory tract because it can lead to trouble with breathing. On the other hand, we know that the vaccines that are available for adults generally have mild side effects, with the one exception that some people who get the protein-based vaccines may develop GBS, or Guillain-Barré syndrome. This is rare, with only up to 10 cases per every 1 million doses of vaccine given, and it hasn't been seen to date following use of the mRNA vaccines, only the protein-based vaccines. We also know that there were concerns about preterm delivery when pregnant people got the RSV vaccine as a way of protecting their babies, but that so far the data have not vetted that concern, so that the rates of preterm labor are not higher following vaccination. And we know that there's another option if you don't want to take that route to protect your baby. They can use the monoclonal antibody products, which are well tolerated by babies with only minor side effects at the injection site, and some will develop a mild rash. Maybe 1 of every 100 babies will get that rash. When our team looked at the relative risks and benefits of using these products to protect against RSV, we felt that for elderly adults, high-risk adults, and young infants, the benefits outweighed the risks. And we hope that when you've reviewed this information, you feel that way too. Thanks for listening today.